Hello, it's Nurse Rob.
Hello, it's Nurse Amy.
What have you been doing, Nurse Amy?
It's very loud. Can we turn it down? I feel like you're screaming at me.
Is
Wow.
that better?
Yes, but I can't really hear myself.
Well, how's that?
Oh, wow.
Is it better? Hi, I'm Nurse Rob.
Hello, it's Nurse Amy. Welcome back to ECTopics. It's been a minute.
It has been a minute.
I'm really sorry. It's
Well,
Dad's fault.
It's so not my fault.
It's always Dad's fault.
I've been absolutely ready to record, but no, you're always busy or asleep.
That's so true. Wow. Yeah. How have you been? How's your weeks?
My week's been big.
Mhm.
What have I been doing? I've been getting ready for a big seminar in Toowoomba.
Yes, that's very exciting.
We have booked our first seminar in Adelaide.
Oh, I'm so excited.
Are you coming to that?
I am forcefully, yes. I will be there with bells and whistles on.
What do you mean forceful? I'm not forcing you.
Well, I've got to meet Nurse Tay,
We have to meet Nurse Tay.
so that's the only reason I'm coming.
Well, okay then. I thought it was something to do with the education that I do, but
God, no.
clearly not.
I'm kidding. Of course it is. What are you
Very good.
teaching?
Okay, it's a program called Acute Deterioration.
Oh, I love that one.
So we've got some rhythm interpretation, we've got some acute cardiac, some acute respiratory, bit of diabetes, a little bit of peds, bit of trauma.
Wow.
Primary and secondary assessment, the A to I assessment.
It's like a mixed lolly bag. You've got a bit of everything, like the lolly snake. What if you've got a mixed lolly bag? Which one are you choosing?
Oh, look, I'd really like those sour ones that are covered and crusted with sugar.
Really? Like the sour worms?
Yeah, like sour worms, and little Coke bottles. I love the little.
Really?
I love.
Wow. See, I'm definitely pink or purple snake through and through.
I do like a chocolate covered pineapple love.
Well, that's weird.
No,
Really?
Oh yeah. I mean,
It's because they're Kiwi, aren't they?
Well, a little bit.
Yeah.
It's definitely giving 1980s.
It's giving New Zealand.
But you know what I absolutely love? You know those bananas?
No.
I like a banana.
You do?
You know they're kind of hard sometimes and sometimes soft.
I hate those.
Do you really?
Yeah.
What about those ones that look like false teeth?
They don't really have any flavour. Like, they're just a bit annoying. They're that annoying, lolly that's always like, the Zupa Dupas. What's your favourite Zupa Duper flavour?
Look, I'm a sucker for anything that's orange.
I am too. I love the orange ones.
Orange ones.
Yeah.
I don't mind the Coke, the cold.
The Coke one, yeah. I really love the orange ones, and I love the pink ones, like the dark pink ones.
Anyhow, welcome to ECTopics, our podcast for nurses. It sounds like we're just doing a mixed bag of lollies review, but yeah, I guess the courses are a little bit like that, aren't they?
They are.
I did plastering and suturing with a group of nurses.
It was very fun. We did. It was fun. I didn't come to plastering, but I did do the suturing, and that was good fun.
You got your stitch on.
I did. Got the stitch on. We did some mattress stitches.
We did some mattress stitches.
And some other stitches.
You learned to do a flap repair.
I love a good flap repair.
So it has been said.
Yeah.
And yes, and your stitching is very, very good.
Thank you.
I can almost get you to start teaching it, I think.
No, absolutely not. That would be the most daunting thing ever. I would get distracted. I'd start talking about lollies and Zupa Dupas.
This is true. Yeah.
Wow. I actually really love suturing. I really, really enjoy it. I'm planning to go to Cambodia in 2025 on another mission trip. It will. And I will be my first one as a nurse that's not a mental health nurse.
I have to ask you a personal question.
Tell me.
When you go to those Southeast Asian countries,
yes,
have you ever had traveller's diarrhea?
Do you know what? I actually haven't. I've been very, very lucky. We did Bali as a family in my schoolies era. And then I've done Cambodia twice. And no, I've never actually had quote unquote Bali belly or any of those. But every time that I've gone to Cambodia, I have had the cholera drink that they give you, and I have had all my shots, and I've been really up to date with all of that. So I think I'm just built different, honestly. I'm just a bit of a weapon.
Well, we have someone in our family who's just recently experienced traveller's belly.
We do. We're not going to mention any names.
We will not mention any names.
Poor darling. No.
Poor darling. But
they are feeling better now, though.
They certainly did want to.
Yeah. It's not good stuff. Would not recommend.
Not recommend. Talk to your GP before you head up those places. I'm off to Thailand to do a bit of trauma work for EMS conferences.
Yeah, without me.
In March.
Yeah.
You're a big girl now that gets an income. You can come to Thailand if you need to.
It's not cool.
Anyway, so when we get to go to these amazing far out places, I think that it's really important that we speak to a GP and we actually make sure that we get our shots, know what you're going into. There's a lot of silly rules that people forget. Just a lot of these little, not quite as advanced as our country is with sanitation. Just brush your teeth with the water. Use bottled water and wash your hands and take hand sanitizers.
Yeah.
All of that really sensible and clever stuff. Eat at reputable places.
Yeah.
And for the love of God, take something to help stop trots when you get it.
Why is it that when I Googled, can you take ondansetron and Imodium at the same time, did it freak out and say no? Apparently it was something to do with you can be more at risk of prolonged QT interval.
Yeah, you can. So ondansetron, particularly when it's metabolized slowly, or in high doses, high concentrations, can cause long QT syndrome.
And same with if you're taking SSRIs, it can cause serotonin syndrome.
So you've sort of answered your question a little bit in talking about serotonin syndrome. So ondansetron, unlike all of the other antiemetic medicines that work on dopamine, ondansetron works on serotonin, so serotonin 3. So it really only comes into its own as an effective medication for vomiting. So when we talk about ondansetron as being an antiemetic, it's my go-to. If my head is in the bucket, I want ondansetron. Yeah. Or something that's a serotonin 3 inhibitor. And
why do we vomit? So explain vomiting.
Okay, yes. So vomiting is there's a couple of different reflexes. So there's an area in your brain called the third and the fourth ventricles, and this is where your cerebrospinal fluid gets secreted. And just underneath that, in an area called the choroid plexus, there is this an area, and it's actually, I kid you not, it's called the emetic center or the vomiting center.
Wow.
And it's this
whole center.
A whole center.
Gosh.
But more than that, the center is divided into 2 rooms. And one room controls nausea, the sensation of nausea, and the other room controls vomiting, which is the actual act of expelling your stomach contents. Now, nausea is the dopaminergic process. So it uses the neurotransmitter dopamine, which is why when we block dopamine 2 with medicines like Maxilon, Stemetil, and any of those big antipsychotic medications or those big antihistamine drugs, like Energen and Lactol and all of those antiemetic, anti-nausea, because they block dopamine, they're a dopamine 2 antagonist, they're effective for both nausea and vomiting. But the act of vomiting, that is serotonergic. So there is some dopamine component to it. If I block dopamine, then it's just vomiting as well, which is why these drugs are also antiemetic. So let's just understand the terminology. Anti-nausea is a medicine that stops you feeling the sensation that you're going to be sick. Whereas antiemetic is a medication that actually stops you being sick, the physical act of vomiting. So if your head is in the bucket and you are spilling and spilling and spilling, then you want something to stop. Then a medication that's going to either block dopamine or block serotonin 3 receptors in your gut. They are going to be the ones they're the medicines that you'll choose. Yes? But if we come back to that area in the brain that controls nausea and vomiting, nausea is not controlled through serotonin pathways in your brain. I mean, nausea is controlled in the brain, but it's not controlled through serotonin pathways in the brain. It's a dopamine, which is why you want a medication that is going to block dopamine. And ondansetron does do that. It's a serotonin drug. So you can see ondansetron is a better drug for vomiting
than nausea.
It's not a drug for nausea. Now,
right.
A lot of people will still give it for nausea. It's probably got some placebo effect because it's so good at vomiting, at preventing vomiting. People assume that it's really good at preventing nausea as well, but ultimately it's an anti-vomiting agent. It's not the best drug to use the others. Anyway,
That's so interesting.
yeah, two different areas within the brain. So both of those areas are triggered by a number of different things. So there is what's called an irrational reflex and a rational reflex. The rational reflex is feedback that comes from your gut. Let's say you were to swallow something that was poisonous, or swallow something that, or ingest something that was off, or has got some sort of compounds in it that would cause you harm if you digested it. Right, you've swallowed it, but if you were going to digest it, then those compounds would cause harm. Then your brain's going to say, well, hang on, that stuff's poisonous. We better get rid of it. So it'll make you sick, and then you see it's about protection.
Yeah.
So if we go back to our evolutionary biology, then we would have vomited to stop ourselves poisoning ourselves accidentally by eating, anything and everything that we could forage and scavenge. Some of the things might have been rancid or off, or rotten, mouldy. That could have caused us to. So those compounds, those poisons, were triggering our brain very quickly to empty the stomach and not digest that.
Yeah.
So you don't just empty your stomach, but you also increase your peristalsis and you go out the other end. So if you're trying to purge your system, you're going to purge in both. So it's a rational reflex.
Yeah.
Now, there's also an irrational reflex, and the irrational reflex is the reflex that people get when they have motion sickness. When somebody is pregnant and they develop morning sickness. These are irrational reflex. It's just chaotic signals going to the brain, and the vomiting centre says, look, we don't really understand what those signals are, those hormonal signals from pregnancy, or we don't really fully understand what all of those signals are. The labyrinth, the balance organ in your ear is telling us that your position is, your head's lying down, but the horizon looks different. Your eyes are giving me different information to your ears are giving me, motion sickness.
Yeah.
The brain says, this is a confusing picture. It may be because you have poisoned yourself accidentally. Let's empty the stomach and empty the bowel.
Yeah.
Let's make you sick.
Yeah.
Just in case you poison yourself. So that's kind of one of the theories as to why we have this irrational vomiting. Did you know that when you vomit, your stomach doesn't contract? So it's not your stomach squeezing and emptying, like squeezing a bag full of yuck. Your stomach actually does the opposite of contract. It relaxes. The stomach actually dilates. And you vomit from your small intestine. So your peristalsis, that wave-like action that goes from the stomach all the way down the bowels to the back door. Well, that turns around and you get a reverse peristaltic.
Oh, that's so cool.
It actually starts down in your small intestine.
Wow.
So you're milking everything that's in your small intestine back up.
Wow.
Which is kind of yuck when you think about it.
That's really gross.
So you think about when somebody first starts vomiting, what's the first thing that they vomit? Their last stage. Yeah. And then what do they vomit? They're vomiting bile. Yeah. That's all coming from the duodenum.
Right.
And then if they keep vomiting and vomiting and vomiting, they're now vomiting fecal fluid.
Shut up.
Shut up.
Shut up. I'll actually vomit thinking about it. Ew. Are you serious? That's just ruined my day.
Well, so don't vomit a lot. Go with your long answer.
Oh my god.
Or something similar.
Why is it that also I was looking at my phone before, not because I was disinterested, but I did a post on Facebook prior to this episode about people asking questions, and there's already like 10 questions, so that's a slay. I recently had a person in ED who had query bowel obstruction.
Yep.
And we put an NG tube in.
Yep.
Well, I did. Successfully, by the way.
Very good.
It was a very exciting moment.
Only 2 pipes.
Just be happy for me, you silly goose.
You've got an NG in your patient, and
they weren't.
It's actually pretty good.
Yeah.
I love it when you put a tube in someone and they say, "Oh, I'm so glad you got that first go because the other person took the germs."
Yeah, well,
do a little happy dance.
It's a lot less traumatic doing an NG in an ED situation than it is in a mental health situation, and I'm just going to leave that there.
Yeah.
So it's nice to kind of not be overly traumatized while doing that.
Yeah.
For me and the patient. Yeah, why an NG tube in the stomach when they have a bowel obstruction? Like, what's the link?
Okay, so
the connect.
Think about your GI.
Yeah.
It's just one big pipe. Goes from mouth to bum.
Yeah. Love it. Slay. Beautiful.
20 feet long.
Yeah.
big long. You have an obstruction halfway along the pipe. Let's say it's down in your small intestine. So there was an obstruction. There was a block. So everything down to the blockage, from mouth all the way through the stomach, through the duodenum, through your ileum, all the way down to where the blockage is in your small intestine, small bowel. It's not moving anywhere. So what's happening is all of that fecal fluid, that undigested product,
Well, it's just sitting there.
it starts to ferment.
Oh.
So normal flora and bacteria start to feast on it.
Oh.
Instead of you absorbing all of those nutrients, normal flora in your gut now start to proliferate and they start to ferment it. And they produce gases and a number of
So it's like kombucha, but in your stomach.
But so much worse.
That's really awful. I hate that so much.
It's like the yogurt from hell.
Wait, can we actually talk about like?
No, we can't.
No, I'm not trying to be dumb.
Or kombucha.
No, wait.
To ask the question.
Can you just tell me what a bowel obstruction really is? Like, I know sort of what it is, but I'm also like, I don't. Do you know what I mean?
So there's a couple of different types. There's an indirect bowel obstruction, which is where so the bowel is just a great big long tube. But it's muscular.
Yeah.
And so that serotonergic peristalsis is the thing that keeps stuff moving. So what if your bowel's peristalsis stopped? Well, what's going to move all of that stuff along? Nothing. So it stays there. So if you're large or small intestine that normally has that milking action, that peristaltic, and that's what you're listening to when you listen to bowel sounds, right? Mm. If you've got that peristalsis happening, then everything is moving towards the back door. Mm-hmm. And eventually, 14 to 16 hours after you've eaten that corn, you're going to see the corn again, right?
Or if you haven't eaten corn, you're still going to see the corn.
It's always corn. Yeah. All right. So so everything's in transit, and that's called gastric transit. Mm-hmm. So through the GI tract. Mm-hmm. Now, if for argument's sake that gastric transit slowed down or stopped, then all of that food now, all of that chime, that semi-digested matter, that's going to not go anywhere because it's not being pushed along through that peristalsis. So the sorts of things that will stop. Let's imagine that you took some sort of medication that slowed down your gastric motility. Imodium is a good example. Mm-hmm. But there's more than that. Mm-hmm. Any of the medicines that are anticholinergic. So even when people take antihistamines for their hay fever, that slows down their gut, right? If somebody's on painkillers that are opioids, we know that opiates and opioids, that causes constipation. Benzodiazepines. So these sorts of medications slow down that gastric motility. Mm-hmm. So if you had a profound slowing down of the gastric motility...
Antipsychotics.
Yeah, well, that's because they're antihistamines. Right? Yeah. So all antihistamines, all anticholinergics, and all opioids, they fundamentally will slow down gastric motility. There's many others. These medications will slow down your GI, sometimes in some people too. Yeah. And there's one obstruction. Other obstructions can be mechanical. So they can be direct obstructions. In other words, it could be a piece of fecal matter that has dried out and just literally got stuck, couldn't get moved. An obstruction, like a plug, a fecal plug. It could be a tumour. There might be swelling or inflammation within the gut lining. So I could have small bowel diverticulum that have varicose veins that have swollen, and that's caused obstruction.
Wow. So a bowel obstruction doesn't mean the bowel's blown up. No, it just means it stopped moving.
Yeah, it's not a bowel explosion.
That's so random.
So
I feel like such an idiot.
Well, you don't have to feel like an idiot. Remember, you're 5 minutes old and nursing, and you're learning this stuff along the time.
I think I'm now 6, actually. Just turned 6 minutes, yeah.
But, to come back to your question, why do I put a nasogastric tube in? Now that you know that if nothing that you've eaten or drunk the last 24 hours has been able to move its way through, it's just sitting in your stomach, and it's just
becoming kombucha.
Why do you want to put an NT tube?
To clear it.
To get rid of it.
Wow.
And if you can get rid of it, then you're minimising the chance that fermentation is going to cause them to vomit.
It's like a mystery.
Not a mystery.
Wow, that's so cool.
So there's a number of different things that we can do to get people moving again. Obviously, we want to withdraw those sorts of medications that have caused their gastric motility to slow right down, if that's the cause. But just aging, as people start to age, they are more susceptible to bowel obstruction. Simply because as we get older, gastric motility slows down. Less of that serotonergic action keeps that peristalsis.
Get some Cloxil.
Yeah, so Cloxil.
Have you seen that ad?
Helpful I do.
I love that ad.
Coloxal is an option for constipation, but we're looking at large.
Yeah. I just wanted to say, look for the smiley face, to be honest.
Look.
Yeah. Okay.
Good question.
Thank you. Yeah.
Is that what somebody asked on?
No, it's just me overthinking my entire shift
Okay.
since Monday. Lol.
Seriously, got to stop overthinking.
Okay. Do you want me to read some questions out?
Yes, let's do it.
Unless you have any burning topics.
No, this is really unscripted. Now I'm frightened.
Yeah, sorry guys. We literally have no.
I feel on the spot.
Don't feel on the spot.
Feeling nervous now.
Don't worry. Okay. Cause of paradoxal effects of medications.
I don't understand the question.
I don't either. What does paradoxal mean?
Okay, so a paradoxical effect of medication is when you give the medication to somebody under the expectation that's going to do one thing and the drug does the opposite. So did the person give an example?
No, it literally just says cause of paradoxical effects of medications.
Okay, so I don't know where they're coming from with that, but you know what's been really topical in the news lately is that they've just recently taken Phenergan not off the market.
Yeah.
So pharmacists are now not allowed to sell Phenergan to parents to give to children under the age of, I think it's 6. Don't come at me. I just haven't done my research.
Yeah. That's okay.
I think that now children under 6 can't have Phenergan. And Phenergan is a classic example of a medicine that has sometimes paradoxical effects. So we know that medications like Phenergan, promethazine, is one of those old first-generation antihistamines that cause drowsiness. And the reason why it causes drowsiness, as opposed to antihistamines that don't cause drowsiness, is because some antihistamines are engineered that they can cross the blood-brain barrier that you get into your brain. And those will cause sedation. So antihistamines will cause sedation if they can get across the blood-brain barrier. And Phenergan's one of those. Phenergan and Polaramine's another one. I know an old-fashioned one called Zadine. We even use an antihistamine as a sleeping agent called Restovit. You might have heard of doxylamine. Yeah? So these old antihistamines are known for providing calming and sedative effects. And they used to be used in children's medication quite routinely. A medicine that was over the counter called Pain Stop used to contain a fair amount of promethazine, Phenergan, in it. And when it was given to children, it not only helped, the pain reliever that was in it not only helped
it would get them some sleep.
Gave them a good night's sleep.
Yeah, cool.
But for a few children, in fact, far more than just a few, some children, they were whizzed up. It was like giving them a Red Bull and a kitten. Buzz. And so these kids, these poor parents, it's 10 o'clock at night, they've got a sick child, they've given them in good faith a dose of nighttime pain stop to their child, thinking that this is a medicine that's going to give their child a nice restful night's sleep. And the kid's up at 2 o'clock in the morning taking shots of espresso, or running around like it's had shots of espresso, because the medicine's had a paradoxical effect.
So it's had an effect that's not expected?
It's not expected, it's not predicted.
Right,
yeah.
Okay.
Another good example is medication like morphine. Sometimes you give morphine to somebody, and the expectation is that it can cause that euphoria. People feel floaty and high and a little bit happy.
Yeah.
But in a few people, it actually causes the opposite. It causes profound
anxiety,
depressive episode and anxiety and hallucinations, and it can make them climb the walls.
That's awful.
That's a paradoxical effect.
Okay. ROTEM in capitals, ROTEM, in massive transfusion protocol.
ROTEM. Look, unless you're working in a resus unit, particularly a big trauma resus unit, you're not going to see or experience ROTEM. So what does ROTEM sound like? What does it sound like?
Rotating?
Rotating.
Wow.
So think of a stick
Yep.
in a little tube of blood.
I remember.
Okay, so the stick is spinning, rotating.
Yeah.
As the blood starts to clot. And what the stick is doing is measuring how sticky and elastic the clot is becoming. So it's called rotation thromboelastometry. Rotation.
Wow.
Thrombo, which is the coagulation process.
Yes.
Remember, that's the formation of the fibrine. Elastometry, measure of the elasticity of the blood. So it evaluates blood clotting really in real time. There are many, many different components of your blood, and we've already done coagulation on TikTok a million times.
Yes, go and look at those vids.
So there's a whole lot of processes and steps that are involved in coagulation. But if I've had a massive bleed and now you want to massively transfuse me, can you see that you will never be able to replace my blood loss with blood?
Mhm.
You can't just give me a blood transfusion of somebody else's blood. You can only give me bits.
Yep.
You can't give me their white blood cells.
No.
You don't give me much of their plasma at all.
No.
I get maybe some highly concentrated fresh frozen plasma from a multitude of donors. I may get a number of packed red blood cells, and I might be lucky to get platelets. But I'm not getting whole blood. So I've been bleeding. I've had my trauma or my surgery. I've been bleeding and bleeding and bleeding. You've been pouring in blood products, packed cells, platelets, and fresh frozen plasma, and those other bits and pieces. And there will come a time where the doctor's going to want to say, well, let's have a look at his blood now and see just how competent he is at coagulating.
Yep.
So we may have given him enough red blood cells, but we're just not really sure what his competence is at coagulation, whether he's coagulopathic still.
Yep.
And rotin is a way of determining what, if any, more blood products I should be getting.
You're so intelligent.
But here's the thing, I've never used it.
Really?
Well,
I guess it's probably a
rotin-
newer thing.
when I was doing flight, we didn't use, and
Yeah.
it wasn't invented yet. Sort of
Yeah.
thing.
Back in the olden days.
And all of the emergency back in the olden days, yes. And back when I was, and in the emergency departments I work in, they're small, rural, and remote facilities, clinics.
Yeah, of course.
So we're not using that sophisticated.
Can't believe there wasn't one in the Taurus.
I know.
Wow.
There was barely electricity in some of those
Oh,
clinics
wow.
I've worked in.
Okay,
We
next.
had running water in one place. That was
Wow.
That felt like 1992.
Okay, so this person asks 2 questions. The first question is, I'd like to know more about cholecystitis and gallstones, please.
Okay, so 2 completely different things.
Yep.
So gallstones is cholelithiasis. Lithos means stone. Iasis, condition of having. Chole, gall. So cholelithiasis is stones in your gallbag, in your gallbladder. Right?
And what are the stones?
They're actually made up of crystals of cholesterol.
Yep.
Yeah, so cholesterol and bile sort of congeals and forms concretions. That's pretty. I don't know if you've ever seen gallstones. Somebody's had
Haven't, no.
You know when people go and buy those polished stones, like beach stones, and they put them in a tumbler and they polish them?
Yeah.
That's what gallstones look like. They're quite pretty. They're not gnarly and stellate like renal stones, like kidney stones. They're actually quite pretty.
Wow.
And they can be benign.
Yeah.
There's people that are listening to this podcast now with gallstones and they don't know they've got until one day they might find themselves going and having a random CT scan of their abdomen. And as they scan the gallbladder, then an incidental finding might be, there's 8 gallstones found in their gallbladder. Right?
Oh, so when do they become an issue?
Well then, okay, so think of the gallbladder has a small tube that comes out.
Yeah.
If the gallstone gets stuck in the outlet,
Pain.
what the gallbladder is going to try and do is squeeze down to squeeze bile into the bowel. So that's the job. The job of your gallbladder is to concentrate the bile that's made upstairs in the liver. So the liver makes the bile, it comes down to the gallbladder, and now the gallbladder stores it and concentrates. When you eat fatty food, the gallbladder contracts. It's got a muscular wall, like a stomach has a muscular wall. The gallbladder's got a muscular wall. It squeezes, and it squeezes, it injects some concentrated bile into the duodenum to mix with the food to digest the fat. Okay. If you've got a stones caught in your gallbladder, sometimes one of those stones might get caught or stuck in the bile duct. And as a result, that's going to cause a massive amount of what's called colic pain. Patient gets a terrible right upper quadrant colicky. So it's called cholelithiasis. Now, if that happens off that contraction, sometimes the gall bag itself, the gallbladder, can become inflamed.
Cholecystitis.
So that's cholecystis. Gallbladder, bladder. Cholecystitis is gallbladder inflamed. And so it can be completely independent of gallstones, or a person can have gallstones and have no colitis, but it's very, very uncomfortable. And if it continues, then a bit like an appendix or a tonsils, they can be removed.
Okay. Next question is Ozempic and potential negative side effects on the pancreas.
Too soon to really make a firm call on that.
Yeah, I feel like it's a pretty new drug.
Yeah. So when you say Ozempic, I guess what we need to do is not single out one brand. So semaglutide and liraglutide and dulaglutide, all of the glutides. So these are all GLP, glucagon-like polypeptide 1 mimics. These are medicines that mimic the effect of a group of hormones in your body that are naturally secreted in your body called GLP-1, glucagon-like polypeptide 1. These hormones are not secreted from the pancreas itself. These hormones are secreted from specialized eye cells within the duodenum. So when you eat food, eye cells secrete this GLP-1, and GLP-1 then goes to the pancreas and says to the pancreas, hey, I know you used to like waiting for blood sugar to rise before you started making insulin. You know, the pancreas makes insulin.
Yeah.
And so for many, many years, we believed that as blood sugar level rose, that triggered the insulin to be secreted from the pancreas. But we now understand that there's also another mechanism by which we release insulin, and that's this GLP-1. So GLP-1 goes to the pancreas and says, hey, listen, I know you normally wait for blood sugar level, but old mate's just unwrapped a Mars bar. He's munging into some Tim Tams as we speak.
Yeah.
Sugar is coming. Start making insulin. So it kind of preps the pancreas to start making insulin pending sugar coming.
Yeah.
Because the patient's starving.
Sure.
That's one of the functions.
Sure.
So it does have a mild effect on the pancreas itself, but no more than sugar.
Yeah, I know a lot of people are using it now for polycystic ovarian syndrome, for weight loss, diabetes, lots of, it's definitely one of those newer drugs that seems to be becoming a new wonder. Okay, next question, which I actually think we'll need to do a video on TikTok on because it's probably more of a demonstratory kind of video, but C-spine precautions, assessment and clearance. What's in, what's out, what's the evidence? It's a really good question. I was literally talking to you about it the other day.
That's a huge question. So
they don't teach you this in uni.
Almost certainly what's out is
anything.
a stiff neck collar.
Yeah.
So we used to put stiff neck collars on a patient. A fellow called Binger, Scandinavian Journal of Trauma, did some work around that and looked at the value of putting a stiff neck collar on somebody when there was a suspicion of having a neck injury, and found that no, the stiff neck collar wasn't doing anything. The stiff neck collar was contributing to harm. The stiff neck collar does contribute to an increase in intracranial pressure, which is not good if they've had a head injury.
Had vibes.
And the stiff neck collar can cause things like pressure injuries. So it causes more harm than it ever did good. There's not a single nurse listening to this podcast that believes for a second that a patient with a stiff neck collar was immobilized. And so if the whole reason that you're putting a stiff collar on me is to stop me from moving, it's not going to work.
Yeah, and it's also just bloody uncomfortable.
It's not just uncomfortable, it just doesn't work.
Yeah.
So what's in is a soft collar.
Yeah.
So a soft collar is in, and then so does a soft collar stop me moving? No. But a soft collar says to all the people around my bed, hey, don't bump the bed. Yeah. I might have a sore neck. Yeah. There could be something going on. Yeah. Now, to clear a C-spine, we need to get a decent X-ray, a lateral and an AP X-ray of the patient's neck, and all 7 cervical bones, including, and then T1, so all 8, the top 8 bones need to be on view, and then it will be decided as to whether there looks like there's any narrowing. Now, if there's any kind of question that you could have some neurological deficit, then of course they're going to keep you as still as possible. Yeah. We used to believe that the smallest amount of movement of somebody's neck, even when they did have a broken neck, the smallest amount of movement would be a life-threatening, a life-threatening problem. But now we don't believe that. We believe that the injury that the patient has when they sustain their injury is not extended. So we don't extend somebody's injury. We just believe that the patient should sneeze or cough or vomit, and they'd be paralysed for the rest of their life.
Yeah.
Now we don't actually believe that's the case.
Oh, that's good.
But the vast majority of people who have a spinal cord injury, and this is kind of really important. It blows the minds of those when I run my trauma classes. A spinal cord injury is not caused because it was severed. Your neck wasn't severed. You didn't break your neck and a shard of bone went through your spinal cord and cut your spinal cord and left you paralyzed. Not how it works. What happens is the bone that encases your spinal cord that is fractured when you have a cervical fracture or a thoracic bone swells, and now into the tunnel through which your spinal cord travels, that swelling pushes onto the spinal cord, cutting off the spinal cord's blood supply. You see the spinal cord, as it loses its blood supply, the cord tissue, it dies.
Yeah.
So you've actually got an ischemic injury. It's like a pressure inside. So movement of that patient's neck really doesn't change that pathophysiology. So if the person's going to be paralysed, it wasn't because we moved them or we got them out of the car roughly or we transported them roughly or we moved them the fracture. So that movement of the neck, whilst we do want to keep them still to keep them safe and to maintain an airway, it's not as vital anymore because we understand the vast majority of the pathophysiological consequences of a neck injury are a secondary injury caused from that swelling.
Yeah.
Spinal cord had been.
That's shit.
So treatment's going to focus on reducing that edema.
All right.
So medication use, but tried all sorts of things over the years, going in and doing decompression, surgery, decompression to remove pieces of bone to make more space, to steroids.
So when you are moving patients, what's the vibes? How are we doing it safely?
So for movement from bed to bed, we need to use a standard log roll procedure.
Yeah.
So one person on the head and a minimum of two, best to have three, on the patient's body. And of course, all 3 to 4 clinicians are going to roll the patient over onto the side to put like a pat slide or some sort of a spine board underneath them to shift them from one bed or one trolley across to the next trolley. We just want to minimise the amount of movement. Remember, movement equals disruption of a bleeding blood vessel. And a bleeding blood vessel may just bleed more and cause more swelling into that lumen, that tunnel that the spinal cord lives in. So we want to minimise movement to minimise disruption of any.
So the person on the head, what should they be doing? Where should their hand be?
On the head, never the neck. On the head and the neck. So you'll see some people grab the patient's shoulders and hold the head with their forearms.
Yeah.
That's just no.
Bad vibes.
It's completely bad.
Why?
What's happening is the patient can still nod. They've still got their chin down to the chest or chin up extension, so they can still do extension. Now it may stop that yaw. And it may stop rotation, but it doesn't stop flexion or extension. So you must hold the patient's head. And I might actually do a little.
We should.
I'll do a TikTok video, and I might use you as my patient, and I'll just demonstrate how to hold.
Yeah, I think that's a really good idea.
Yeah.
Okie dokes. Next question: effects of low sodium bicarbonate levels on patients.
Okay, so sodium bicarbonate is actually made by your red blood cells. Well, not sodium, but bicarbonate. It's made by your red blood cells from carbon dioxide. So carbon dioxide dissolves in blood, becomes carbonic acid. There's an enzyme in your red blood cell called carbonic anhydrase, which converts that CO2 into bicarb. So if you've got low levels of bicarb, which is our major alkaline substance, so we've got lots of acidic things in the blood and lots of alkaline things in the blood. The dominant alkaline substance in the blood is bicarb. So when our bicarb levels drop, this causes we develop acidosis. And that sort of acidosis is referred to as metabolic
acidosis. Yeah.
So I can either have an accumulation of acid or I can have a decrease in bicarb, and both of those will cause a pH.
So low sodium levels.
Not sodium, but
So sodium bicarbonate isn't a thing.
yeah, it is, because bicarbonate, you know how when we talk about electrolytes, we've got positively charged electrolytes like sodium, potassium, magnesium, calcium, they're all positive. And then we've got negatively charged electrolytes like bicarbonate and sulfate and phosphate. They're all negatively charged. Chloride, they're all negatively charged. So they are paired with each other. They counterbalance each other. So a sodium, which is positive, will always bond with a negative, an anion. So cations, which are positive, and anions, which are negatively charged. And bicarbonate's just one of those negatively charged ions. So hydrogen is positively charged. So when I mix hydrogen with chloride, then I get hydrochloric acid. Right? When I take sodium, which is positively charged, and mix it with chloride, which is negative, and I get sodium chloride. So if I take sodium that's positively charged and mix it with bicarbonate, which is negatively charged, then I get sodium bicarbonate.
Okay, but what does it mean?
Well, it just means it's paired.
So
what's happening is bicarbonate's always going to be looking for a partner to join it.
Right.
To maintain its neutrality. And so it binds with the most abundant positively charged ion in your blood, and that's sodium.
Right. So low sodium just means that you have an increased low sodium bicarbonate.
Low bicarbonate
means that you have an increased risk of acidosis or that you are acidotic.
But you'll be acidotic. Yeah. But low sodium doesn't necessarily influence bicarbonate.
So what does
bicarbonate will just try and find some other positively charged ion to partner with.
they'll break up and be like, fuck you, I'm gonna find someone else.
It's just Love Island. That's what it is.
I love Love Island. I really do. And so does Dad. He just doesn't want to admit it. We watch it together and he's all in it. Like his phone's not even on. He's like full in it. Anyways, I'm not editing that.
A glow up.
We love that show. Glow Up is so good. Okay, so position of V3 lead in a 12 lead ECG. Is it fifth intercostal left of the sternal border or between V2 and V4? Or are these considered the same landmark?
Can you just repeat that question?
Okay, basically, position of V3 lead in a 12 lead ECG. Is it fifth intercostal left of the sternal border or between V2 and V4? Or are these the same landmark?
They should be the same landmark, but yes, it's the absolute midpoint between V2
and V4.
And V4.
Yeah, I always go.
It often is on the bonus.
I always do V1, V2 in the normal like fourth intercostal space, and then I do V4 under nipple, like anatomical nipple line. And then I'll do V6, and then I'll put V5 in between V4 and 6, and V3 in between 2 and 4. That's always how I do my ECGs. I don't go 1, 2, 3, 4, 5, 6. My brain doesn't work like that.
I go 1, 2,
4, 6.
And then I'll put 3 and 5.
Yeah.
Midpoints. Yeah.
Wow. So we're just so related.
I guess.
Okay. Irregularities seen in blood work post chemotherapy, please. High white blood cell count, maybe?
Not high. Well, it depends if you not high.
Well, low because it kills off everything.
Post chemotherapy, yeah. So chemotherapy, I mean, this is a blanket statement that's not always entirely correct.
And also, disclaimer, this isn't really our area.
So not. But chemotherapy is, so when we're talking about chemotherapy, we're talking about a family of cytotoxic medications that are designed to kill off rapidly dividing cells, right? Cancer is rapidly dividing cells, but so is the cells that produce hair, so hair follicles, the cells that line your gut, the cells that produce hair, the cells that line your gut, the cells that produce blood, so bone marrow.
Mm.
So bone marrow is constantly turning over, and it's constantly reproducing cells, including white blood cells. So typically you would expect post-chemotherapy, post a dose of chemotherapy, you're going to expect that white blood cells are going to start to take a nosedive,
Mhm.
and that makes a person more susceptible to infection.
Yeah, absolutely.
As they become more and more leukopenic, in other words, white blood cell count drops,
Mm.
they become more susceptible to infection.
Yeah.
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 And when they get infection, they're less capable of fighting said infection.
Yeah, immunocompromised.
The other thing that you typically associate cytotoxics with is loss of hair.
Mm.
And it's not just the hair on your head, it's hair everywhere. So it's eyebrows, facial hair, moustaches, underarms, everywhere.
Mm.
So even that sort of hair that you grow on your toes,
It's really offensive.
Yeah.
Continue. He's
the
being a
lining,
dick.
the lining of your gut.
Yeah.
And it's everywhere. Remember, we talked about the gut before. It's one great big pipe from mouth to bumhole. So you think of every tissue from mouth to bumhole. So mouth ulcers, esophageal ulcers, stomach ulcers, and ulceration all the way through your small intestine and large intestine.
That's shit.
Well, it produces it, but it's not a party. Can I say?
It's not a fun adventure.
It's really, really rough.
Yeah.
It's really, really rough.
I would really like to get into oncology one day, I think. I think I'd really
Good
enjoy.
luck with that. Not my thing.
Well, I just think it would be really interesting. And I think being a part of someone's hopefully successful cancer treatment would be really special.
Yeah.
Even though it's not always successful, I still think it would be a pretty special thing to be a part of.
There's no question that it has to be a very, very rewarding area. But honestly, I take my hats to our oncology nursing colleagues
me
out
too.
there that are looking after patients. And nurses and paramedics and students that are listening that are fighting their own battles with cancer either themselves or in the family.
Yeah.
Chemotherapy is it's not an easy ride.
Yeah. It's shit. It's
I
so shit.
had one lady who I was nursing. She said, I never realised beforehand, even despite everybody telling me how bad it would be, I never realised just how hard this was going to be, this journey. She said, I spent the first week post my very first dose of chemotherapy worried that it was going to kill me, that I was going to die. And she said the second week I was worried I wouldn't die. If I just stopped there and then and was taken out of the misery that this medicine was giving me.
Yeah.
So my heart absolutely goes out to anyone that's experiencing that. I just don't think I've got the emotional fortitude.
I just
be able
think
to
it's
care for
shit.
people
Like you're
with cancer.
literally choosing to poison your body so that you can
You're trying to
not
poison the
die.
cancer.
Like
You're
it's
poisoning the cancer.
yeah, but your whole body becomes affected.
Do you know when people survive and go into remission and they start to grow hair back, it doesn't always grow back the same colour.
Really?
So they might have had blonde straight hair and it can grow back, curly red hair, or it can grow back.
Oh, that's so interesting.
They could have been somebody with a wave and a brunette. Their hair has grown back, a really lighter shade.
That's so cool.
Sandy straight hair.
Yeah. Wow. That's interesting. I love it. But yeah, definitely take my hat off to anyone and my heart goes out to anyone who's currently going through that journey. And
I actually follow a few people that are struggling through their journey on social media.
Yeah.
I'm just going to say Zoe. Just search for Zoe's story on TikTok. Just follow Zoe. I just love her stuff.
Yeah.
She's not a nurse, but she speaks almost fluent. She speaks that language.
I always do, hey.
It's just lovely. She's really struggling with chemo and she's taking us with the journey. So I think that, hit up some social media and provide some support to those people.
Good to spread awareness about
they're
that.
having a rough trot. So Zoe, if you're listening, I don't know if you follow our podcast, but if you're listening to the podcast, we're thinking about it.
We sure are. And I actually don't have any more questions for you.
Well, I reckon we've done a job. Probably wrap up. What do you think?
I reckon we wrap up. Thank you, everyone.
We answered all of the questions that you have, nursing.
I did. Yes, we did.
We talked about antiemetics.
We did.
We talked about anticholinergics.
We did. Thank you guys so much for listening. And this has been another episode of ECTopics. Sorry that you had to wait so long for this episode. Again, it's Dad's fault.
It's always Dad's fault.
We love you guys. Thank you for listening to our Topics podcast, and we hope you have a slay rest of your day or
Thanks
whenever you're
for playing,
listening.
everyone. I'm Nurse Rob.
This is Nurse Amy. Bye, guys.
See you next time.